Hello everyone and welcome to today's webinar on high-yield UKMLA topics in ear, nose and throat. My name is Dr Hester Lacey and I'm the ClinicalKey Student Assessment Editor and the author of Crash Course Surgery 4th edition, and I'll be hosting this webinar today. Elsevier is a global publishing company that owns both the ClinicalKey Student Question Bank, which contains over 6,000 questions on clinical medicine and basic science, and new medicine topics targeted to the UKMLA curriculum. Crash Course is a series of high-yield textbooks relating to all medical topics targeted at UK medical finals. Today's webinar will consist of 10 high-yield questions relating to core topics from the UKMLA syllabus for ear, nose and throat. We will go through the questions and the associated correct answers, and then the topics in detail, with all information coming from NICE or Society guidelines. Let's get started with the first question. I'll read the question and then give you about 30 seconds to think about the correct answer. A 17-year-old boy has 6 hours of generalised abdominal pain after 10 days of a worsening sore throat and general malaise, with fatigue, headache, fever and reduced oral intake. His girlfriend is also unwell with similar symptoms. His temperature is 37.8 degrees, pulse 122 beats per minute, and blood pressure 88/67 millimeters of mercury. He has bilateral tender cervical lymphadenopathy, scleral icterus, and severe left upper quadrant tenderness, guarding and abdominal rigidity. Which complication has most likely developed? A. Acute renal failure. B. Hepatitis. C. Liver hematoma. D. Pneumonia. Or E. Splenic rupture. So this question is a two-stage question requiring application of knowledge, where you determine the correct diagnosis and then the most likely complication that is developed associated with that underlying diagnosis and the clinical presentation. The underlying diagnosis in this case is infectious mononucleosis, and hence the correct answer is E, splenic rupture, and we'll go through why in the following slides. Infectious mononucleosis typically relates to the Epstein-Barr virus infection. It is highly contagious, spread through bodily fluids or vertical transmission, and hence partners who share bodily fluids may commonly be co-infected with this condition. It most commonly presents in adolescents and young adults, and there is a 4 to 7 week incubation of infection, resulting in a lifelong latent carrier state. It presents with a flu-like prodrome of fever and general malaise, and subsequently pharyngitis and tonsillitis, with also hepatosplenomegaly common. It may be associated with a maculopapular rash, which typically presents in patients which have been prescribed amoxicillin for a suspected tonsillitis infection, which is actually infectious mononucleosis. In this picture here, you can see the typical white-grey tonsillar exudate, which may be subsequently confused for a bacterial tonsillitis infection. This is a typical example of the rash that may develop in patients with infectious mononucleosis if they are treated with amoxicillin. However, the rash is non-specific and may be macular, petechial, urticarial, or an erythematous maculopapular rash as seen in this case. The diagnosis of infectious mononucleosis is confirmed with a monospot test, which is a finger prick blood test which detects heterophile antibodies in response to EBV infection. A full blood count and a blood smear will demonstrate lymphocytosis with over 10% atypical lymphocytes. And if monospot is negative but the diagnosis is suspected based on the clinical presentation, there you can do EBV viral serology. If there is hepatic involvement, liver transaminases and LDH may also be raised. The management of infectious mononucleosis is, as many viral infections, conservative with regular analgesia, Contact avoidance to limit disease spread by avoiding kissing or eating or sharing eating or drinking utensils with other people, and thoroughly clean any items that may have been contaminated by saliva. It's important to inform patients about the disease course, which can be up to 2 to 4 weeks, which is one of the key differentiating factors from tonsillitis bacterial infection, is the prolonged disease course. And patients should avoid heavy lifting and contact sports for 4 weeks due to the underlying risk of splenic rupture, which we saw in this question. Further complications include Guillain-Barré syndrome, meningoencephalitis, autoimmune hemolytic anemia, acute renal failure, pericarditis, pneumonia, and otitis media, and symptoms should be safety netted in regard to these and any evidence of severe infection or dehydration. Splenic rupture is one of the key features in exams that you see in relation to this condition, typically in young patients who play sports and then develop abdominal pain after a flu-like prodrome and sore throat. Splenic rupture can develop following minimal trauma in patients with infectious mononucleosis due to the splenomegaly that develops with the disease. Hence, it is essential to inform patients and safety net them about this risk in the first month of the illness. Symptoms of splenic rupture include acute diffuse abdominal pain worse in the left upper quadrant, with guarding and rigidity as peritoneal signs relating to fluid in the abdomen. Hypertension and tachycardia may develop with severe hemorrhage. In this CT scan, we can see a dark hematoma lateral to the ruptured spleen following trauma, as seen by the red mark here, which is highly suggestive of splenic rupture. Moving on to the next question. A 48-year-old man has 1 month of gradually worsening left hearing loss, ringing in the ear, and dizziness. He has an ataxic gait. Weber's test lateralizes to the right, and Rinne's test is positive bilaterally. Which test is most likely to confirm the diagnosis? A. Audiometry. B. Brainstem auditory evoked potentials. C. Contrast MR of brain. D. CT of temporal bone. Or E. A pan endoscopy. I'll just give you about 30 seconds to think about the correct answer. The correct answer in this case is C, contrast MR of brain. This question is another application of knowledge question requiring you to determine the underlying diagnosis and then the most appropriate investigation that will confirm this diagnosis, which in this case relates to acoustic neuroma. An acoustic neuroma, or a vestibular schwannoma, is a slow-growing benign tumour arising from Schwann cells in the vestibular cochlear nerve. It is closely associated with neurofibromatosis type 2, and these patients typically present with bilateral tumours. Symptoms relate to tumour expansion into the internal auditory canal, which causes pressure on the vestibular cochlear nerve. With cochlear nerve involvement, you get unilateral, gradual onset sensory neural hearing loss, which is the most common symptom, and tinnitus. With progressive vestibular nerve involvement, you get dizziness, which may be described as vertigo. However, true spinning vertigo is uncommon because of the slow-growing nature of the tumour and compensation by the central nervous system for gradual peripheral vestibular input loss. Patients may also experience ataxia and with an unsteady gait and disequilibrium. Later symptoms are caused by pressure of adjacent structures within the cerebellopontine angle and posterior cranial fossa. With trigeminal nerve involvement, patients may have facial paresthesia or hypoesthesia with unilateral facial pain. With facial nerve involvement, there may be peripheral unilateral facial weakness that can progress to paralysis. With compression of the cerebellum, ataxia can become worse, and with the fourth ventricle, hydrocephalus can result in severe tremors. Weber's and Rinne's tests are common bedside tests that can be used to determine the likely etiology of hearing loss as sensory neural or conductive. The patient in this case presented with evidence of sensory neural hearing loss, which can then guide the further investigations that are most appropriate relating to the underlying diagnosis. Weber's and Rinne's tests use a 512 Hz tuning fork. Weber's test is performed by tapping this tuning fork and placing it in the midline of the forehead and determining whether it is louder in either ear. In the normal patient, the sound of the noise should be equal in both ears with no lateralization. Rinne's test is performed by placing a vibrating tuning fork on the mastoid process, which tests bone conduction, and then once this noise is silenced, moving it to just in front of the tragus to assess whether the noise is still there, which it should be, as air conduction is meant to be better than bone conduction. This test is described as positive. This patient presented with a lateralizing Weber's test and bilateral positive Rinne's test, which suggests sensory neural hearing loss. In sensory neural hearing loss, Weber's test lateralizes to the unaffected ear, suggesting a sensory neural loss in the alternative ear. In conductive hearing loss, Weber's test is louder in the affected ear, and Rinne's test will demonstrate bone conduction being better than air conduction in the affected ear, which is described as a negative Rinne's test, and this is typically because there is a peripheral obstruction of the noise transmission into the ear, suggesting conductive hearing loss. The diagnosis of acoustic neuroma is made following a presentation of clinical sensory neural hearing loss confirmed on audiometry, which demonstrates high frequency hearing loss, and then a contrast MR of brain, which will delineate the lesion in the vestibulocochlear nerve. Brainstem evoked audiometry can be performed, which demonstrates a delay in cochlear nerve conduction time. However, imaging evidence with MRI is required to confirm the diagnosis. This MRI demonstrates a large acoustic neuroma originating from the right cerebellopontine angle, which is compressing the pons and resulting in shift of the fourth ventricle. This patient may present with some of the neurological features and hydrocephalus that I mentioned previously. However, they uncommonly present this large. In this audiogram, we can see a unilateral high-frequency sensory neural hearing loss in the right ear. You can see on this audiogram that at the higher frequencies, the patient requires significantly louder in the right ear to hear the frequency compared to the left, suggesting a sensory neural hearing loss. Moving on to the next question. A 4-year-old boy has 2 weeks of worsening left ear pain, discharge, hearing loss and fever, despite 1 week of oral antibiotics. His temperature is 38.8 degrees C. There is purulent discharge from the left ear, periauricular tenderness and boggy swelling behind the ear. And we can see the clinical presentation in the picture on the right. Which is the most likely diagnosis? A. Acute otitis media. B. Malignant otitis externa. C. Mastoiditis. D. Pinnahematoma. Or E. A postauricular abscess. I'll just give you 30 seconds to think about the correct answer. The correct answer is C, mastoiditis, which is a complication that can develop following an acute otitis media infection, suggested in this case by a preceding history of 2 weeks of worsening left ear pain. Acute otitis media describes inflammation and effusion in the middle ear. It most typically relates to an upper respiratory tract infection, but can also relate to bacterial infection. It typically affects children, most commonly under 4. Symptoms include otalgia, so ear pain, hearing loss in the affected ear, with flu-like symptoms of fever, malaise, and coryza, which are common with a viral cause of symptoms. Otoscopy demonstrates erythema of the external auditory canal and tympanic membrane, with evidence of tympanic membrane bulging, air fluid levels and loss of the cone of light suggested by the effusion, as seen in this image. If the effusion is significant, tympanic membrane perforation can develop, which can result in discharge from the external auditory canal. Acute otitis media is typically a self-limiting infection which resolves over 3 days to 1 week. Regular analgesia should be recommended, as well as rest and oral fluids. Antibiotic therapy can be considered, however, is not typically recommended as most presentations relate to viral infection. Antibiotics may be indicated in people with evidence of severe systemic infection, perforation, under 2 with bilateral symptoms, or any underlying immunocompromise, and typically involves 5 to 7 days of oral amoxicillin or a macrolide. A backup antibiotic prescription can also be considered if symptoms fail to improve within 3 days or worsen, but patients should be advised not to collect the prescription unless their symptoms do extend over 3 days. Analgesia and anaesthetic ear drops can also be offered to those not prescribed antibiotics, which typically involve phenazone with lidocaine. Any patients with suspected complications of acute otitis media, including meningitis, mastoiditis, intracranial abscesses, sinus thrombosis, or facial nerve paralysis, should be urgently referred to hospital and treated with intravenous antibiotics. Complications of acute otitis media typically relate to intracranial spread of infection. Complications can include recurrence, hearing loss with severe infection, tympanic membrane perforation, which can require repair, mastoiditis, which we saw in this case, meningitis, intracranial abscesses, sinus thrombosis, or facial nerve paralysis. Mastoiditis describes the intracranial spread of a middle ear infection to involve the mastoid air cells in the mastoid sinuses, resulting in inflammation and destruction and formation of a pus-filled mastoid cavity. Symptoms include evidence of systemic illness, fever, and a prolonged course of illness over 2 weeks, hearing loss in the affected ear, tenderness over the mastoid process, and swelling with forward displacement of the pinna, as seen in the photo we looked at earlier. CT temporal bone can be performed to confirm the diagnosis, and in this case we can see evidence of destruction of mastoid air cells on the left-hand side and collection of pus within the cavity. This flowchart provides an overview of the management of suspected mastoiditis. Patients should be urgently referred to hospital and ENT and treated with empirical intravenous antibiotics and analgesia. Mastoiditis is typically a clinical diagnosis. However, if there is any evidence of treatment failure with symptoms over 48 hours or any intracranial complications, CT temporal bone can be performed to confirm the diagnosis, which will demonstrate mastoid air cell opacification or erosion and pus in the mastoid cavity. If there is evidence of chronic symptoms, ear fluid MCMS can be performed to confirm the underlying etiological organism, and topical antibiotic drops can be prescribed, and ENT referral should be made for subsequent imaging to confirm the diagnosis and consideration of surgery. Surgical interventions include, for early infection, a myringotomy and tympanostomy tube insertion to facilitate middle ear drainage, and in any severe or refractory cases, a mastoidectomy can be considered, involving removal of the mastoid air cells via a post-auricular incision to facilitate pus drainage. Moving on to the next question. A 62-year-old man has sudden painless bleeding from his left nostril. He has hypertension and atrial fibrillation, managed with ramipril, bisoprolol, and apixaban. His pulse is 85 beats per minute and blood pressure 134 over 98 millimeters of mercury. There is profuse, fresh, red bleeding from the left nostril. Which is the most appropriate next step? A. Arterial embolization. B. Bilateral septal pressure. C. Nasal cautery. D. Nasal packing. Or E. Topical vasoconstrictors. I'll just give you 30 seconds to think about the correct answer. This question requires knowledge of the steps in management of acute epistaxis, of which the first step is B, bilateral septal pressure. Epistaxis, or nose bleeding, is very common and relates to damage to the blood vessels of the nasal mucosa. Its etiology can be defined by the location of vessel trauma. Anterior epistaxis, or bleeding from the nostrils, accounts for 90 to 95% of cases and arises from vessel trauma from Kesselbach's plexus in Little's area, which describes the anastomosis of the anterior ethmoidal, sphenopalatine, greater palatine, and superior labial artery. Posterior nose bleeding, or bleeding through the posterior nasal aperture, is much less common, accounting for 5 to 10% of cases, and relates to damage to the vessels in Woodruff's plexus, which is a convergence of the sphenopalatine and posterior ethmoidal arteries. Here we can see an image depicting the locations of bleeding in anterior and posterior epistaxis. Posterior epistaxis typically is associated with more significant nasal or intracranial pathology, causing trauma to the vessels in the posterior nasal aperture, which can include malignancy, and this is a red flag for nasopharyngeal carcinoma. Anterior epistaxis is much more common and typically relates to local trauma or benign pathology. The causes of epistaxis can include any trauma or inflammation on topical drugs, which typically relate to anterior epistaxis. Posterior epistaxis can relate to damage interruptively. Vascular causes such as hereditary hemorrhagic telangiectasia and Weger's granulomatosis, or tumours such as nasopharyngeal carcinoma. Systemic risk factors include things increasing the risk of trauma to blood vessels or increasing the risk of bleeding. So trauma to blood vessels including hypertension, atherosclerosis, and things increasing the risk of bleeding such as hematological disorders, and anticoagulants and antiplatelet use. Environmental factors are also key, including temperature, or in very cold environments this can increase the risk of nose bleeding. Management of acute epistaxis is with an A to E approach. In any patients who are hemodynamically stable, which would be the vast majority of cases, basic first aid is appropriate, including bilateral septal pressure and subsequent nasal cautery or packing if this fails to cessate the bleeding within 10 to 15 minutes. Topical antiseptics or vasoconstrictive drugs can be used as adjunctive measures if required. If bleeding is not controlled, hospital admission is required for definitive ENT management. In any hemodynamically unstable patients, emergency hospital admission is required for resuscitation with blood products and surgical hemostasis. This flowchart provides an overview of the management of epistaxis. After bilateral septal pressure of 15 to 20 minutes, the source of the bleeding should be attempted to be identified with anterior rhinoscopy. If the source can be identified, topical vasoconstrictors and nasal cautery can be used, and supportive measures such as topical anaesthetics or analgesia can be prescribed. If there is persistent bleeding, nasal packing should then be considered with nasal tampons, ribbon gauzes, or absorbable dressing. And if bleeding persists after that, it is more likely that bleeding relates to a posterior source, which requires ENT consult. Moving on to question 5. An 8-year-old boy has 2 days of worsening sore throat, difficulty swallowing, and fever. His temperature is 39.3 degrees C, pulse 144 beats per minute, respiratory rate 35 breaths per minute, and oxygen saturation 91% on breathing air. He is agitated, speaking with a muffled voice and drooling, with an audible rattling sound as he breathes. I'll just give you 30 seconds to think about the correct answer. So the most likely diagnosis in this case is B, epiglottitis, and we'll go through why in the following slides. Epiglottitis relates to progressive epiglottic inflammation relating to underlying bacterial infection. In exams, the association that is common is a Haemophilus influenza type B infection in an unvaccinated child. However, since the introduction of the HIV vaccine in 1985, the incidence of HIV epiglottitis has significantly decreased. Epiglottitis is now more common in adults than children and is typically related to Streptococcus or Staphylococcus infection. Symptoms of epiglottitis include severe and acute onset of a sore throat with fever, a muffled voice and drooling and hoarseness. Typical signs include sitting forward in a tripod position due to difficulty in breathing, inspiratory stridor, and evidence of severe and systemic infection, including tachycardia. And hypoxia and dyspnea is common, as there is airway obstruction. Epiglottitis is a medical emergency, hence it is a clinical diagnosis, and importantly, the throat of anyone with suspected epiglottitis should not be examined, as this may precipitate or trigger airway closure. Hospital admission is required, and urgent ENT and anaesthetics consult. The airway should be secured, and then management of the underlying bacterial infection involves intravenous antibiotics and supportive measures. If the diagnosis is in doubt, a lateral neck X-ray can be performed, which demonstrates the classical thumbprint sign suggesting epiglottic inflammation. Question 6. A 45-year-old woman has 3 months of recurrent dizzy spells with right hearing loss, ringing and a feeling of fullness in the ear, which occurs suddenly and can last several hours before spontaneously resolving. Weber's test lateralizes to the left, and Rinne's test is positive bilaterally. Which is the most likely diagnosis? A. Acoustic neuroma. B. Benign paroxysmal positional vertigo. C. Labyrinthitis. D. Meniere's disease. Or E. A vestibular migraine. I'll just give you 30 seconds to think about the correct answer. The correct answer in this case is D. Meniere's disease. Meniere's disease is a disorder of the inner ear relating to raised endolymph pressure in the membranous labyrinth, and the etiology is not fully understood. Diagnosis is made with evidence of over 2 spontaneous episodes of true rotatory vertigo between 20 minutes or 12 hours, audiometrically documented low to medium frequency unilateral sensory neural hearing loss, which locates to the affected ear on at least one occasion before, during, or after an episode of vertigo. There must be fluctuating oral symptoms of hearing loss, tinnitus, or a feeling of fullness in the affected ear, and symptoms must not be better accounted for by an alternative vestibular diagnosis. Here we can see the membranous labyrinth, which in Meniere's disease, impaired resorption of endolymph results in raised endolymph pressure. It's idiopathic and may be related to viral infections or autoimmune disease, or in patients with an atopic history, but the etiology is not fully understood. Audiograms should be performed, which will demonstrate low to medium frequency unilateral hearing loss in the affected ear. Management of Meniere's disease involves ENT referral with formal audiology assessment to confirm the diagnosis. Patients should be given risk counselling regarding driving, swimming, or operating machinery due to the sudden onset attacks of debilitating vertigo. Short-term symptomatic relief can be considered with prochlorperazine, which is an antiemetic, or antihistamines, which are vestibular suppressants. However, chronic use of these is contraindicated as they can inhibit central compensation of ataxia, which can produce gait and postural instability. Lifestyle modifications that can be recommended and may offer benefit include stress reduction, a low sodium diet, and trigger avoidance if there are identifiable triggers. And beta-histine is a histamine analogue which improves the circulation of the inner ear and can be considered for long-term prevention of attacks. Vestibular rehabilitation with habituation exercises can be beneficial in some cases. If there are severe and debilitating symptoms, hospital admission for intravenous labyrinthine sedatives can be considered in the acute attack, and chemical ablation with intratympanic gentamicin or steroid injections can be offered for long-term prevention of attacks in severe cases. Moving on to question 7. A 61-year-old man has 2 months of fatigue, poor concentration and memory, and morning headaches. He has type 2 diabetes and hypertension, managed with metformin and ramipril, and drinks 12 beers a week. His pulse is 87 beats per minute and blood pressure 165 over 82 millimeters of mercury. He is overweight with a wide neck circumference. Which is the most useful scoring criteria? A. Centaur score. B. The DHI score. C. The Epworth Sleepiness Scale. D. The Fever Pain score. Or E. The Stop-Bank score. I'll just give you 30 seconds to think about the correct answer. All these options relate to scoring criteria that can be used in ear, nose and throat. The Centaur score and Fever Pain score can be used to suggest the need for antibiotic prescriptions in acute tonsillitis infections. The DHI score describes the Dizziness Handicap score, which describes a handicapping effect of dizziness. And the Epworth Sleepiness Scale and the Stop-Bank score relate to the underlying diagnosis, in this case, of obstructive sleep apnea. So the correct answer here is E, the Stop-Bank score. Obstructive sleep apnea is a sleep-related breathing disorder with recurrent episodes of complete or partial obstruction of the upper airway during sleep. Complete obstruction causes apneic episodes with complete airflow obstruction and temporary absence or cessation of breathing, and partial obstruction results in hypopnea episodes with decreased airflow. Symptoms and signs relate to airway obstruction and micro-interruptions of sleep, including excessive daytime somnolence, irregular nocturnal respiration and snoring with witnessed apneic episodes while sleeping, unrefreshing sleep and fatigue, and impaired daytime concentration. Risk factors for obstructive sleep apnea include increasing age, male sex and obesity, a family history, any underlying nasopharyngeal obstruction or craniofacial abnormalities, and neuromuscular disorders reducing the strength of the muscles supporting the airway. Lifestyle factors are key and include smoking, alcohol, and sleeping supine. A diagnosis of obstructive sleep apnea is made following a history with typical features suggestive of the disease and assessment of any underlying risk factors and associated conditions. Clinical features which may suggest the diagnosis include micrognathia and retrognathia, evidence of nasopharyngeal obstruction, and elevated blood pressure, BMI, and neck circumference. Scoring criteria can be used to support the diagnosis, including the Stop-Bank score, which is specifically used to suggest a risk of OSA, and the Epworth Sleepiness Scale, which is used to determine the effect and extent of sleepiness impacting day-to-day living. However, this is not to be used in isolation to determine referral. Therefore, the Stop-Bank criteria is more useful in isolation. The Stop-Bank questionnaire specifically screens for obstructive sleep apnea and contains questions relating to snoring, fatigue, observed apnea episodes, and risk factors including elevated blood pressure and BMI, age, a wide neck circumference, and a male gender. The management of obstructive sleep apnea involves a referral to a sleep clinic for polysomnography to confirm the diagnosis, and typically the key in management is conservative measures to reduce risk factors, including weight loss, exercise, smoking cessation, alcohol reduction, and sleep positioning to avoid sleeping supine. Patients must inform the DVLA of their condition, as there is a risk of micro naps during driving, which can cause accidents. Medical management, if there is failure of conservative therapy, involves continuous positive airway pressure or intraoral devices if patients cannot tolerate CPAP, and any management of comorbidities. Here we can see the difference on polysomnography trace between central and obstructive sleep apnea. Central sleep apnea relates to underlying medical conditions affecting the nervous system where spontaneous cessation of respiratory effort occurs, reducing airflow, whereas in obstructive sleep apnea, respiratory effort is continuous, but the obstruction results in cessation of airflow. The complications of obstructive sleep apnea are significant, hence effective management of this condition and risk reduction is essential. Complications can include hypertension, hypoxia-induced arrhythmias, pulmonary hypertension and respiratory insufficiency, sudden cardiac death, polycythemia due to chronic hypoxia, accidents relating to microsleeps, which can be car accidents or occupational accidents, which can be life-threatening, an increased risk of vascular dementia, and a risk of weight gain and obesity with fatigue. Question 8. A 22-year-old man has 2 weeks of recurrent dizzy spells when he stands up, with unsteadiness, nausea, and blurred vision, lasting up to 30 seconds, following left myomectomy for recurrent middle ear effusion 3 weeks ago. Rotatory vertigo and upbeat nystagmus are reproducible when he lies down. Which is the most appropriate next step? A. Antiemetics. B. Epley manoeuvre. C. Neurectomy. D. Vestibular suppressants. Or E. Watchful waiting. I'll just give you 30 seconds to think about the correct answer. The correct answer in this case is B, the Epley manoeuvre, as in this case the presentation likely relates to benign paroxysmal positional vertigo. Benign paroxysmal positional vertigo is an inner ear disorder which relates to dislodging of the otolith organs in the inner ear, which causes migration into one of the semicircular canals, disrupting endolymph dynamics and resulting in repeated episodes of positional vertigo. Symptoms are triggered by changing of the head position, which results in dislodging of the otolith organs, and it's the most common cause of clinical vertigo. The most common demographic to present is in middle-aged women. Precipitant factors include head injury, a prolonged recumbent position, following ear surgery, or any inner ear pathology such as vestibular neuronitis, labyrinthitis, or Meniere's disease. The management of BPPV involves confirmation of the diagnosis with a triggering manoeuvre, which is typically the Dix-Hallpike manoeuvre. Management can involve watchful waiting, which can be offered to the patients. However, symptoms typically resolve quicker with treatment, hence repositioning manoeuvres should be offered. The Epley manoeuvre is a manoeuvre that can be performed by a trained clinician in primary care, which will restitute the otolith organs in the semicircular canals and resolve the symptoms. Brandt-Daroff exercises are a simplified version of the Epley that can be offered to patients to perform themselves at home. Symptoms typically recover over several weeks even without treatment, and there should be 4-week follow-up if symptoms have not resolved, with consideration of ENT referral. Neurectomy is a definitive management that can be considered in chronic or refractory cases. This diagram demonstrates the steps of the Dix-Hallpike and Epley manoeuvres, which can be performed in quick succession to both confirm the diagnosis and treat the symptoms. The Dix-Hallpike manoeuvre in steps 1 to 2 involves a sudden change in head position, which triggers displacement of the otolith organs into the semicircular canals. The Epley manoeuvre in steps 3 to 5 is performed to restitute the otolith organs and resolve the symptoms. Question 9. A 26-year-old woman has 10 days of facial pain, nasal congestion and fever, which initially improved but has since worsened. Her temperature is 38.1 degrees C. She has bilateral maxillary tenderness with purulent discharge from the left nostril. Which is the most likely diagnosis? A. Allergic rhinitis. B. Bacterial rhinosinusitis. C. Nasal polyps. D. Primary ciliary dyskinesia. Or E. Viral rhinosinusitis. I'll just give you 30 seconds to think about the correct answer. So the correct answer in this case is B, bacterial rhinosinusitis, and we'll go through why in the following slides. Rhinosinusitis describes symptomatic inflammation of the mucosal lining of the paranasal sinuses and nasal cavity. It is classified based on the time course of symptoms. Acute sinusitis describes symptoms that completely resolve in under 12 weeks. In acute viral sinusitis, symptoms typically last under 10 days. And acute post-viral rhinosinusitis can be diagnosed where there is worsening symptoms after 5 days or persistence over 10 days. Acute bacterial sinusitis describes development of secondary bacterial infection, which results in a prolonged course of symptoms. Chronic sinusitis describes any symptoms that last over 12 weeks or longer. Bacterial rhinosinusitis can be diagnosed with symptoms that last over 10 days, discoloured or mucopurulent nasal discharge, and evidence of this mucopurulence on anterior rhinoscopy as seen in this image. Severe local pain typically over the maxillary sinuses, a fever over 38 degrees C, and a marked deterioration after the initial milder phase relating to the viral infection, which suggests subsequent bacterial superinfection. The management of rhinosinusitis involves reassurance that the disease is typically benign and self-limiting, provision of regular analgesia and nasal saline or decongestants that can be bought over the counter if the patients feel they benefit. In bacterial rhinosinusitis, antibiotics can be considered, however they are not routinely indicated but may be required in severe symptoms or in cases of concurrent immunosuppression. Urgent hospital admission is advised if there is evidence of sepsis, any orbital or cranial spread of infection, and reduced GCS. However, this is very uncommon. The final question. A 24-year-old woman has 3 days of right ear pain, discharge, and itch. There is tenderness on right tracheal palpation and sloughy white discharge in the external auditory canal. Weber's test lateralizes to the right, and Rinne's test is negative on the right. Which is the most appropriate management? A. Oral toilet. B. Hydrocortisone and gentamicin drops. C. Olive oil drops. D. Oral amoxicillin. E. Phenazone and lidocaine drops. I'll just give you 30 seconds to think about the correct answer. In this question, we have a woman with unilateral ear symptoms with evidence of a conductive hearing loss, with lateralization of Weber's to the affective side and a negative Rinne's test on the affective side. The most appropriate management is B, hydrocortisone and gentamicin drops, as the symptoms are suggestive of underlying otitis externa infection. Oral toilet describes irrigation or microsuction, which can be used in conditions of excessive debris in the external auditory canal. Olive oil drops can be recommended in patients with excessive earwax, and oral amoxicillin or phenazone and lidocaine drops can be considered in the management of acute otitis media infection. Otitis externa describes diffuse inflammation of the skin and subdermis of the external ear canal. It most commonly relates to Pseudomonas or Staph aureus infections. Fungal infection, typically relating to Aspergillus or Candida, is associated with chronic symptoms. Risk factors include contact dermatitis affecting the ear, acute otitis media, any ear canal trauma or obstruction of the ear canal, Water exposure is the typical risk factor seen in exams, and otitis externa is often described as swimmer's ear. And fungal infection is associated with diabetes mellitus and any prolonged topical antibiotic use. Otitis externa typically presents with symptoms of unilateral itch, pain, and discharge with hearing loss. There may be tragal or pinna tenderness, and on otoscopy, erythema, edema, and copious purulent debris may be evidenced in the ear canal and in front of the tympanic membrane. The external ear canal may be so swollen that effective otoscopy is not possible. Otitis externa is typically managed conservatively. Patients should keep their ear clean and dry and particularly avoid any water entering the ear. Ear trauma should be avoided and no use of cotton buds. Management of the underlying risk factors is important, such as diabetes and fungal infection. Oral toilet with microsuction or irrigation may be considered if there's excessive debris in the ear canal. Medical management, which is offered in most cases, involves a topical antibiotic and corticosteroid drops. Typically, gentamicin and hydrocortisone drops are used. Gentamicin treats the infection and the corticosteroids reduce the inflammation, which is primarily for symptomatic relief. Complications of otitis externa include cellulitis of the skin surrounding the ear canal with external spread of infection, abscesses which can develop around infection of the hair follicles in the cartilaginous part of the external auditory canal, which are typically due to Staph aureus infection. In chronic infection, ear canal scarring and stenosis can develop, and tympanic membrane perforation can develop with severe canal swelling. Rarely, a complication known as malignant otitis externa can develop. Malignant otitis externa is a severe complication of otitis externa, which describes progressive infection of the external ear canal, causing osteomyelitis of the temporal bone and adjacent structures in the skull base. It is associated with diabetes, older age, local radiotherapy or previous surgery to the affected ear. Symptoms include unremitting pain, purulent ear discharge, systemic illness with hemodynamic instability, hearing loss, evidence of granulation tissue in the ear canal, and evidence of facial nerve palsy, so loss of movement of the affected side of the face. The typical presentation of a malignant otitis externa infection is of a non-resolving otitis externa infection of many weeks duration. It typically presents in older adults with diabetes and most commonly relates to underlying Pseudomonas infection that invades the underlying soft tissues. CT temporal bone should be performed, which demonstrates bony erosions on the affected side and soft tissue filling the external auditory canal. Any patient with suspected malignant otitis externa should have urgent intracranial imaging with CT or MRI of the temporal bone, which will demonstrate bony erosion, soft tissue infection, intracranial extension of infection and local abscesses. ENT should be urgently consulted, and in the immediate instance, hospital admission for systemic intravenous antibiotics is required. After acute stabilisation of the patient, systemic or topical antibiotics should be offered for 6 to 8 weeks, and oral toilet can be offered to improve for symptomatic relief. ESR or CT scans should be repeated to monitor the response to treatment to ensure resolution. Any patient with refractory symptoms should be considered for surgery, which can involve bony debridement, abscess drainage, or definitive mastoidectomy. That brings us to the end of our 10-question webinar on high-yield UKMLA topics relating to ear, nose, and throat. We covered questions relating to infectious mononucleosis, acoustic neuroma, otitis media, epistaxis, epiglottitis, Meniere's disease, obstructive sleep apnea, BPPV, rhinosinusitis, and otitis externa. Thank you for joining us today, and looking forward to seeing you next time.